Hey everyone, and welcome to The Explainer. Today, we're tackling a really important and often misunderstood topic: schizophrenia. It's a serious mental illness that can fundamentally change how a person sees reality. We're going to break down what it is, what it looks like, and how it's managed. So, let's dive right in.
All right, so here's our game plan. We'll start with how schizophrenia is actually defined. Then we'll get into the symptoms, what we call positive and negative symptoms. After that, we'll take a quick look at the science behind it, then jump into the medications, their serious side effects, and why patient safety is everything. And to wrap up, we'll see how schizophrenia fits into a whole spectrum of related disorders.
So, first things first, what exactly is schizophrenia? Let's get into the nitty-gritty of the official criteria that clinicians have to use to make a diagnosis.
It's a great question, and the answer is really specific. See, it's not about just one bizarre behavior or a single symptom. It's about a whole pattern that has to unfold over a specific period of time.
At its very core, schizophrenia is what we call a psychotic disorder. And all that means is that a person is having a really hard time telling the difference between what's real and what's not. To even get to a diagnosis, a person needs to have at least two of these key psychotic symptoms. But as you're about to see, when they show up and for how long is just as important. And this is where time becomes absolutely critical. A diagnosis is never made in a single moment. Those really intense, active, psychotic symptoms have to be going on for at least a month. But the overall illness, including some of the quieter signs, has to stick around for a total of at least 6 months. This timeline is what really separates schizophrenia from other, more short-term psychotic issues. Okay, so we've got the when down. Now let's get into the what. What does this illness actually look like? Well, the symptoms are usually split into two big buckets: positive and negative. This is such a great way to think about it. Positive symptoms are not good things. They're things that are added to a person's experience that shouldn't be there, like hearing voices. On the flip side, negative symptoms are things that are taken away or are missing, like the motivation to get out of bed or the ability to feel happy. So let's break down those positive symptoms. You have delusions, which are these rock-solid false beliefs. A classic example is persecutory, where someone is convinced the FBI is after them. Then you have hallucinations, which are sensory experiences with nothing there. Hearing voices is the most common by far. And you absolutely have to know about command hallucinations. This is when the voices tell someone to hurt themselves or others, and that is a true psychiatric emergency. Another huge positive symptom is disorganized thinking, and you can literally hear it in the way someone talks. It can be something like echolalia, just repeating what you say back to you, or clang associations, where they link words together because they rhyme, not because they make sense. In the most extreme cases, it becomes what we call word solid, just a jumble of words that's completely incoherent. It's a powerful sign of just how scrambled things are inside the brain. Now let's talk about those negative symptoms. We often call them the A list. Anhedonia is the inability to feel pleasure from things you used to enjoy. Alogia means poverty of speech, where answers are super brief. And avolition is a profound lack of motivation. It makes even simple tasks feel impossible. These might not be as dramatic as hallucinations, but trust me, they can be just as devastating to someone's life. You know, the illness usually follows a certain path. It often starts with the prodromal phase with some subtle warning signs. Then comes the acute phase with the full-blown psychosis. With treatment, a person can enter the stabilization phase, where things get better. And the long-term goal is recovery, which is all about getting back to daily life and trying to prevent a relapse, which is unfortunately pretty common. So, what is actually going on in the brain to cause all of this? Well, let's turn to the biology and some of the leading theories behind what's happening. Yeah, there's no single simple answer here. It's a mix of things. Structurally, in the brain, we often see things like enlarged ventricles and a little less overall brain volume. Chemically, the big player is dopamine. Too much dopamine activity is really strongly linked to those positive symptoms, like hallucinations. Of course, genetics are a factor. If a parent or sibling has it, your risk goes up. But it's not just biology. Environmental stress and trauma also play a really big part in the story. So, knowing all that, how do we go about treating it? This brings us to the main tools in the toolbox: antipsychotic medications. And they generally fall into two main groups. This chart lays it out perfectly. The first-generation drugs, the typicals, are the older ones. They work mostly by blocking dopamine. They're pretty good at hitting those positive symptoms, but they have a high risk of causing some serious movement-related side effects. The newer second-generation drugs, the atypicals, are a little different.
They block both dopamine and another chemical, serotonin. That helps them treat both the positive and the negative symptoms, but they have their own risk, metabolic problems like serious weight gain or diabetes. Look, these medications can be absolute game changers, but, and this is a big but, they are not without risks. Managing their side effects is a huge part of treatment, and it's all about keeping the patient safe. So you'll hear the term EPS a lot. That stands for extrapyramidal side effects. And those are the movement problems caused by the older antipsychotics. We're talking painful muscle spasms or a restless can't-sit-still feeling called akathisia. It's all because of that dopamine blockage. To fight it, doctors often prescribe another type of drug to help get that chemical balance back in check. And then there's something even more serious called tardive dyskinesia, or TD. This is a big deal because it can show up late in the game after years of treatment, and it can be permanent. It involves involuntary movements like lip smacking or grimacing that can get so bad they interfere with eating or breathing. That's why anyone on these meds needs to be regularly checked using a special screening tool called the AIMS. Okay, everyone, listen up because this next one is a full-blown medical emergency. It's called neuroleptic malignant syndrome, or NMS. It's rare, but it's deadly. The best way to remember the signs is the mnemonic fever. A super high fever. Confusion or altered mental status, that's encephalopathy. Vital signs all over the place. Elevated labs, and severe muscle rigidity. If you even suspect NMS, you stop the antipsychotic immediately. And this is why teaching patients about their meds is so important. For example, one very effective drug, clozapine, can cause a dangerous crash in your white blood cells. So patients have to get their blood drawn every single week. Another drug, ziprasidone, won't even get absorbed unless you take it with a 500-calorie meal. That's a pretty big meal. And people need to know that everyday things like smoking or even drinking grapefruit juice can totally mess with their medication levels. All right, for our last section, let's zoom out a little bit, because schizophrenia doesn't exist in a vacuum. It's actually part of a whole family of related psychotic disorders called a spectrum.
This really helps clear things up. Think of schizoaffective disorder as schizophrenia plus a major mood disorder, like depression or bipolar disorder. Delusional disorder is pretty much what it sounds like. Someone has delusions, but not all the other symptoms. And then schizophreniform and brief psychotic disorder are basically time-limited versions of schizophrenia. Schizophreniform lasts less than 6 months, and a brief psychotic episode is just that, brief, lasting less than a month, and it's often triggered by major stress.
And with that, our deep dive comes to a close. We've walked through the diagnosis, the symptoms, the biology, and the treatments. But understanding the clinical side is really just step one. It all leads to a much bigger question for all of us. Now that we know what this illness involves, how can we, as communities, as families, as friends, do a better job of supporting people on their road to recovery? That's the real challenge. Thanks for joining me on The Explainer.